Welcome back to Psychobabble. I'm your host, Hannah Spear. First, I just want to say there are some new subscriber benefits out on Substack, so if you haven't seen them yet, please head over to check those out if you're curious about conservative psychiatry. Today, I'm joined by Robert Whitaker, an award-winning journalist famous for his works Mad in America and Anatomy of an Epidemic. He's also founded a website which is really cool. It's called Mad in America, where they really advocate for the victims of psychiatric treatment and medications. And he's also a very sought after speaker and lecturer. And he's really spiked some vital conversations around the safety and efficacy of psychiatric medication. Thank you so much for joining me today, Robert.
Well, thanks for having me here. It's a pleasure to be here.
So what brought you into this? Because for 3 decades you've written about this issue, well, a range, but really focused in on the psychiatric treatment. What got you started there?
Yeah, I mean, it's actually a journalistic impulse, which I think is important. When I co-founded a newsletter that looked at the testing of clinical drugs, and also really what we were looking at was the financial influences on that testing. This was the late 90s. And by this time, it was becoming quite clear that clinical trials of new drugs that were in development in order to get FDA approval, those trials were not scientific enterprises to really flesh out the safety and efficacy. They were designed really as, from a marketing point of view, how do we show some efficacy on something and also create a story that will make our new drug successful in the market compared to existing drugs. Now, this was happening in many disciplines, but psychiatry was seen as the medical discipline that was most compromised. So, for example, in 1998, New England Journal of Medicine tried to do a review of antidepressants, and they looked for experts in mood disorders. They couldn't find anyone who didn't have financial ties, any expert who didn't have financial ties to drug companies. So I was writing about that corruption, but I still believed in the sort of conventional narrative. So I started looking at psychiatry because they were seen as the most corrupt industry. But I still believed in the conventional narrative we were being told at that time, which was that they had discovered that chemical imbalances were the cause of major disorders. And we now had new drugs that fixed those chemical imbalances, like insulin for diabetes, which is a narrative of great progress. But what happened was I co-wrote a series for the Boston Globe on abuses of psychiatric patients in research settings, okay? And it's really not important. It had 4 parts, and it was a very well-received series. But as I was doing that series, I came upon 2 studies that belied that narrative of progress. One were studies done by the Harvard medical researchers, which reported in a 1994 paper that long-term recovery rates for schizophrenia patients had declined in the last 20 years rather than improved, and were now no better than they had been in the first third of the 20th century, which belies that sort of narrative of progress where the antipsychotics come in are so much better. And then second and most important, I came upon 2 studies by the World Health Organization that compared outcomes for schizophrenia patients in the U.S. and 6 other developed countries with outcomes, and all diagnosed by Western doctors, in India, Nigeria, and Colombia. And twice they found, one study was 2 years in length, the other 5 years, that patients in the developing countries had markedly better outcomes. So much so they said, living in a developed country is a strong predictor you won't have a good outcome if you're diagnosed with schizophrenia. So, of course, you wonder, well, this all sort of belied this narrative of progress. Now, after the first such study, the World Health Organization investigators hypothesized maybe the reason for the better outcomes in the poor countries, or the developing countries, is the patients are more medication compliant. They take their antipsychotics, okay? They don't resist them. So in the second study, they looked at medication usage, and what they found is in the 2 countries with the best outcomes, India and Nigeria, they used the drugs acutely but not chronically. They didn't maintain people on the drugs long term. So that belied the narrative that I believed in, which these drugs fix a chemical imbalance and they're absolutely essential for people with schizophrenia, and that belied that. And that began an investigation to see if the scientific literature supported the narrative that was being told to the public. Now, that's a journalistic enterprise. And what you find is that It doesn't. This is sort of bottom line.
Mm-hmm.
We have this story of a pharmacological revolution that takes off in 1955 with the introduction of antipsychotics into asylum medicine, right? This is a great advance in care.
Yeah.
But when you actually go to outcomes from that time, you don't see that. And what you do begin to see right away in the research literature, and this is both for antipsychotics and antidepressants, people are starting to worry, like, are we increasing the chronicity of these disorders? So, long-winded story is, a journalist what is a journalist's duty? The journalist isn't to make scientists feel good or the powerful feel good. The journalist's duty is to try to be a conveyor of information that is as true as possible within the confines of science. And if you have sort of a story of science that is at odds with what is being told to the public, such as the chemical imbalance story, your duty as a journalist is to tell what the science is saying. And that's really why I got started in this. And then the reason I've kept at it is it's caused the fact that we've organized ourselves around that false narrative of science has caused such harm to people. It leads to a misuse of the drugs and a misunderstanding what's going on in you. So that's why I've stayed with it. I think it's changed our society and in so many ways to great harm.
Still today, I have patients coming in thinking that they have a chemical imbalance and ask about how is it again with which neurotransmitter. Funny, I actually went yesterday to my books. I just did the board certification test here in Switzerland. So I went to these books, the Bible, it's the Stahl, the Essential Psychopharmacology, and those still, you're laughing.
I know these books
still
too well.
Talking about. I know. I think that's what I assumed, that there's a serotonin hypothesis that there's decreased serotonin because the drugs increase the serotonin. So, would you talk about that? What you've found?
Yeah, this is really important because, again, I want to emphasize I started out a believer in that story because as a reporter, when I called people up, they said, oh, they need these drugs because they fix the chemical imbalance, talking about the antipsychotics, antidepressants. But what you find when you look into that hypothesis, the hypothesis arises in the 1960s, both the low serotonin or the low monoamine theory and the dopamine hyperactivity theory. But it doesn't arise from investigations or discoveries in people so diagnosed. So it's not that they find people with depression have low serotonin in the 1960s or that people with schizophrenia or psychosis have too much dopamine. What they come to understand is how the drugs act on the brain. So they come to understand that the first generation of antidepressants, the tricyclics and the monoamine oxidase inhibitors, they up serotonergic activity by keeping serotonin in that synaptic gap between neurons longer than normal. So they hypothesize if the drugs are effective, and if they do this, maybe the pathology is the opposite of that. And there was the same thing with the dopamine hyperactivity story. What do antipsychotics do? They block dopamine receptors. They put a brake on it. So they hypothesize maybe schizophrenia is due to too much dopamine. Now, once you have that hypothesis, now you have to trace in the scientific literature the effort to test it, because you test hypotheses. And as early as the late 1970s, actually, there was questions being raised about this dopamine hyperactivity theory. And in 1983 or 84, the NIMH tested in a big study. The NIMH is the National Institute of Mental Health in the United States. It's the biggest funder of research in the world, the biggest government funder. And they looked to see, do people with depression have abnormal serotonin levels prior to going on the medication? And they didn't find it to be so. They basically found that with their measurement of metabolites and stuff, it sort of was like a bell curve. And that bell curve was the same as for, normals. And they also found that there was no relationship to where you fell on that bell curve of serotonergic metabolites in response to antidepressants. So as 1984, they said, we're just not finding that there's a lesion in the serotonergic system. Now, for the next 14 years, they do all sorts of ways to look for serotonergic deficiencies. And in 1998, which is how many years ago? 26 years ago, you can read the American Psychiatric Association's own textbook, and it says, we've investigated the monoamine hypothesis of depression, and we just haven't found evidence for it. And then they even say that it was sort of a silly hypothesis from the beginning because there's no reason that the pathology of a disorder should be the opposite of the mechanism of action. So it's really declared dead, the serotonin theory, in 1998. But what does the American Psychiatric Association continue to tell people? We now know that depression is a disease caused by abnormalities in the serotonin system, and the drugs fix those abnormalities like insulin for diabetes. In the United States, we heard that both from the American Psychiatric Association and from pharmaceutical companies. Now, there's one final sort of irony to this whole story. So in other words, the hypothesis fell apart long ago, but they kept maintaining it.
Yeah.
They kept telling it to people. Why? Because and you know, this is what I asked researchers this once. Why do you tell people this? You know what they told me? Because it gets people to take their drugs. And we know it's like a soundbite to get them to take their drugs.
It's very pragmatic, but
It's
yeah. Mm-hmm.
And I said, yeah, but you're not supposed to lie to patients. And it was sort of, well, it's just a little white lie. But that's the long story. I could go in the schizophrenia story, but the story is it was a hypothesis born from understanding the mechanism of action. They didn't find that people with depression had low serotonin before going on the drugs. But the final chapter in this story is they did find that once you go on an antidepressant, which interrupts the normal reuptake of serotonin, acting as an accelerator, what does your brain do? It puts down the brake on its own serotonergic machinery, actually dials down its density for serotonergic receptors. So the real irony of this whole story in the scientific literature is that the drugs actually create the very abnormality hypothesized to cause the problem in the first place. And then finally, just to complete this story, yeah, you have doctors even saying that's the reason we have such poor long-term outcomes.
Right. So it actually ends up down-regulating the receptors, which probably in this hypothesis, they've changed it to there's a decreased number of serotonin receptors. That's not that you have low serotonin, but it just, it doesn't sort of register it that's a nice way to put it. So you're saying that it actually down-regulates the receptors and gives you then withdrawal symptoms if you stay on this drug for a long time. Do you know how long it takes before it starts down-regulating these?
Actually, it's pretty quick.
It's
quite quick. Then the little bit of research that I've seen on this, the down-regulation happens really quickly. But what happens is that initial downregulation triggers all sorts of feedback loops, et cetera, et cetera. And ironically, it's when the feedback loops, it seems, begin to tire out in the presence of this that you start to get some sort of impact from the antidepressant, say after 6 weeks or whatever. But the other thing, what we're talking about withdrawal, they said the longer a person is on it, this is from animal research, it seems the longer it takes for those receptors, if you try to come off, to reset.
So then there's a real issue about informed consent in psychiatric patient. I mean, I know I wouldn't tell patients about this withdrawal symptoms because I wasn't told. Like, that's not in these books. I checked just recently to have, sometimes you think maybe you forgot, maybe it's there. No, they talk about side effects if you stop the medications, which obviously that you have that with several medications. Sounds that's innocent enough, but withdrawal symptoms is not mentioned, and that also makes it impossible to give patients informed consent. What are your thoughts?
Yeah, there's been no informed consent. Basically what happens, at least in the United States, for the longest time, people would go to the primary care or to their psychiatrist complaining of something, unhappiness, of feeling down or whatever. And very quickly they'd leave with a prescription. And the only information was like, it might take a little while for the drug to kick in. And that was basically it. There was no talk about sexual dysfunction. There was no talk about you may have trouble coming off this drug. And so, of course, for the longest time, the profession said, that's just the return of the disease. Those aren't withdrawal symptoms, even though they're so different. So this whole use of these drugs has unfolded in the absence of informed consent, about absence of really how effective they are, what they do to your brain, because if you're told they're fixing a chemical imbalance, that's not informed consent. A minimizing of adverse effects, no talk about long-term impact, and also difficulty coming off. So you're making a major decision about your life in the absence of informed consent.
There's something that's been getting a lot of attention lately, and that is the dramatic effect lifestyle and exercise have on our well-being and mental health. But the difficult thing is to stick with the routine. So what you need to do is to go and check out Pitch Fitness Center. It's a premium wellness gym, and it's gorgeous. It gives you that hotel spa feeling with every exercise, and their kids club is even open on Sunday. So head on over to pitch.ch, that's pitch.ch, and get a discount with our promo code Psychobabble Podcast today. See you there.
A lot of patients would also ask, when do I have to take this my whole life? When can I come? And these were just questions that we can't answer, and we don't want to, because in that moment there's such a desire for the medication on both sides of the table. So, and in Scandinavia, there's the problem that, you don't have a lot of psychiatrists, so you're really there with the patients just 5 minutes and then out. Whereas in Switzerland, every psychiatrist has a degree in psychotherapy. Wow. So that everyone has these, it took a while, but everyone has that hour session with the psychiatrist. But back to the chemical imbalance, did they stop investigating if these hypotheses, or if there's another explanation, another mechanism of action for depression, neurobiological?
Well, they kept searching because they had, the American Psychiatric Association adopts a disease model when they published DSM-3, the third edition of its Diagnostic and Statistical Manual in 1980. So they were looking for pathologies, for abnormalities in brain function. So the chemical imbalance was one of the first one and the longest running one. Just a quick anecdote. I was giving a grand rounds at Massachusetts General Hospital Psychiatry Department shortly after I published Anatomy of an Epidemic. And it was sort of a contentious time. And what they said is, oh, you made it seem like we believed in the chemical imbalance theory. We knew that wasn't true in 1987. And I said, yes, you did, but you forgot to tell the public, and everybody started to laugh. But so then they moved on to different sort of things. Obviously they say there might be genetic causes, or there's some sort of abnormality in the size of like a certain part of the brain. But none of these different theories about what might be wrong with the brain has panned out, where it is actually an identifying characteristic of people with depression. All those studies are based on like composites, the scans or something. The brain is working much differently. Those are composite scans. They're not scans of individual brains that is characteristic of a depressed brain versus a non-depressed brain. So they've moved on to very many different things, but nothing has stood the test of time, at least from my perspective. Do you think anything has stood the test of time?
No, but I'm wondering because why I'm asking that is we have had medications previously where we didn't know the mechanism of action, only a lot later. But like aspirin or beta blockers, we saw it work, so we gave it, we implemented it. And then lithium is still, I don't know your opinion on lithium, if that's, but I think, it's a good drug. It works. Yeah.
No, just going back to this, there's no reason a drug can't be effective if you don't know that, you have some sense of how it's acting on the brain, even though the brain's so complex and you have all these feedback things. There's no reason it can't be helpful if you don't understand the pathology. That's true. Okay. It's not necessary to you can have some humility and say, we just don't know why, but it works, you can say. Now, I will say with the antidepressants, at least in clinical trials, its benefit over placebo is pretty minimal. That's in industry-funded trials. And then in the trials that we had funded by the NIH in real-world trials, they really didn't beat placebo response rates even in the short term. And in the long term, you see this decline in outcomes. So the problem with antidepressants is the research literature on outcomes, quite apart from the chemical imbalance story, just doesn't show. It shows maybe a marginal benefit over the short term, but it doesn't show a benefit over the natural course of the disorder. That's the outcome problem. With lithium, at least I know lithium. Do you know a guy named Masargami by any chance? He's an expert in mood disorders from the United States. He's at Tufts Medical School. And he's a critical thinker, okay? He's a psychiatrist. And when he wrote a paper recently, said, basically we should be using psychiatric drugs only over the short term and in small doses as possible because we have no evidence that they improve long-term outcomes. Except he said lithium. So he said lithium is
Excludes
different from
lithium.
it excludes lithium from that criticism. He says lithium prevents suicide, that sort of thing. And I hear this from many people. Okay, lithium is a drug that really works. It sort of knocks down the mania, and people can do many often fine on it. The only thing that when a guy named Martin Harrow did a long-term study of lithium, and he was a NIMH funded, probably the most prominent researcher in the United States on long-term outcomes, he found that 20 to 25% were good responders to lithium and could stay on it, and they just did fine. But he found many others would quit, and once they quit, they actually relapse back into manic episodes much more quickly than in the natural course of the disorder. So there was this worry that because some people don't like lithium, it was shortening the cycles between episodes. So it's, one of the things here is people have different reactions to these drugs, right? It's not a one size fits all. And if you believe in Martin Harrow's research on lithium, there's certainly a group that it benefits long-term, it tolerates it well. But he didn't find it was improving outcomes for manic depressive patients on the whole. And there was some data showing that once lithium was introduced, rehospitalization rates for manic depressive illness or bipolar actually increased. Because
Interesting.
people
When was that?
That was published, lithium gets introduced in the 70s, Harrow studies in the 90s, but the rehospitalization came out in the early 80s. If you want, I can send it to you. The increase in rehospitalization.
That's very interesting. Yeah, because I've seen that myself, that is a problem. Because lithium, for our listeners who don't know, it's used for bipolar 1 disorders, and it really takes care of those manias. It's a very good drug, but it makes you extremely drowsy. It's really like walking through water. They can't think properly. It also does horrible things cardiovascularly, increases your weight. They don't like to stay on the drug. They quit it because they feel good, and they think, oh, well, I'm good anyway, and then we'll stop taking the drug, and then we're back to square one. So you're saying that this then happens more often.
It increases the rapid cycling. Yeah. So, and you're exactly the reason you hear from patients who stop, that's exactly what they say. It's because it's like having a blanket placed over you. You can't really enjoy life fully. And then there's all these physical adverse effects. So basically that's what Harrow found. So many people were quitting it because of these things. And then when they quit it, they started recycling more and even had more severe episodes. So that's sort of the story.
Yeah, because I noticed that if you then restart the lithium, it doesn't work as well as it did previously. That's the case for a lot of these psychiatric drugs, and why you then switch from one antidepressant to the other. Speaking of, can we go back quickly to the antidepressants?
Sure.
I wanted to know, in which cases would you say, okay, here I would recommend trying an SSRI, an antidepressant?
Well, first of all, I want to say I'm not a clinician, so I don't feel like I should ever be giving advice, even in sort of saying when you should recommend. However, this goes back to informed consent. You could present to the person, here's the likelihood that you'll have a better response on the drug to not being on the drug. And here's your risk associated with that. Short term, the withdrawal, and the long term. And all I can say is that, with that sort of context, then people can make a decision about what they want to do. I do think part of the informed consent is to talk about how there are natural recovery rates from depression. But there are people, I know you do, of course, know many more people, but I know many people who felt the drugs really helped them. Especially over the short term. It got them out of some sort of funk or whatever. But then they weren't into a form of care that said, now we'll help you get off. In other words, the drug helped you stabilize, helped you get through a difficult time. And then there was no okay, it worked, but you don't have to be on these drugs for life. Let's see if we can help you get off. So I guess the important part is the answer to you. This is, I believe psychiatric drugs can have a place when used in a thoughtful manner within a full understanding of whatever efficacy shows up, and compare that to like natural recovery rates, and also with a full awareness of what the drugs do, what are some of the adverse effects, and are there problems coming off these drugs?
I mean, the best case I found in the studies that I just saw here were 1 in 3. Does that tally with what you found when it comes to efficacy of the antidepressants? That it helps 1 in 3 in an acute case?
So you do see that 1 in 3. In other words, that basically maybe the depression goes away, right? It's like a pretty full-bodied
remission.
Response. Remission.
Yeah, to be more specific, full remission. Yeah.
Yeah. Now, I will say in the real-world trials, it was lower. It was more like 25% or even lower in the real world. When I real-world trials, I mean, industry has like exclusion-inclusion criteria that prevents many people from joining. But when they've done studies in real-world patients, including one I think in Switzerland, it was about 25%. Okay, fine. That's great.
Yeah.
But what's the natural remission rate? Because you can't just attribute all the effectiveness to the drug. What's the natural recovery rate? And so, for example, when the NIMH did a study on, well, what is the course of unmedicated depression today? At the end of 6 weeks, I don't think it was over 25%, okay? But the difference was when they looked at this is it continued to get better. And at the end of 1 year, it was 85% were in remission. Well, we don't see 85% remission rates, at least in the United States, with antidepressants. Nothing close to that. So all I'm going to say is that 1 in 3 or 1 in 4 is a statistic you get, but it's not a statistic that's compared to placebo. It's just sort of, this is what's happening to people, or even the natural course.
Could it be that depression is such a difficult diagnosis? It's not like you have a study on diabetes and that's what this patient looks like. I mean, depression is so multifaceted, and I find there are these 2 different kinds of patients. You have the patient with their lives are in ruins, and you want to do something now to help them. If I don't sleep, I'm going to lose my job, and you're just trying to improve it now. And then you have the patients who they have great lives. They have everything in order and good education and skills and competence and all that. They're still depressed. And for those patients, I found they do have a great effect on the antidepressants. What are your thoughts on that?
Yeah, well, there's a long history of melancholy and depression, right? Going all the way back to the Greeks. And there's this sense that so many depressive episodes are a response to environment, things that happen to you, okay? That up until 1980 was always seen as those things will generally resolve with time passage, you lost it, you make changes in your life. But then there was another group that was seen as having something really biological inside them. For example, the depression, you couldn't identify something that happened in their life as a particular setback or whatever. Or their sense of depression outlasted what was seen as a normal response. Now, we removed that. American Psychiatric Association removed that distinction in 1980 when it adopted the DSM-3. But all the time before that, there was a distinction between these 2 patients. One group where you couldn't see like a catalyst in the environment for their depression. And those were seen as probably having often seen as having melancholy, a biological process. And then you had ones where people like, oh yeah, sometimes life sucks and you get knocked down, but generally with time, these people will recover. We lost that distinction. By the way, there's clearly also diseases in physical conditions that can lead to depression or associated with depression. Obesity, lack of exercise. There's all sorts of, and there's cardiovascular conditions. There's all sorts of physical conditions which are also associated with, a low mood, a depressed mood. So one of the things I think we've lost in psychiatry is looking at actual physical causes that could be explaining that the state is related to these physical, diseases, what they might be. Could be very many different things.
Yeah.
Anemia.
What do you think that comes from? We're so desperate for it to be neurobiological. Or maybe that's why they're holding on to this hypothesis, although it was disproven 2 decades ago. And still, it's not that we're searching for a different explanation. We're just sort of hoping that no one will talk about it again. But it's this desperation for a neurobiological explanation.
So yeah, they wanted to put everybody into that neurobiological camp, right? When we said historically there's really 2 camps. There's an environmental camp, and maybe there's a biological camp. This goes back to 1980. What happened is in the 1970s, American psychiatry, as a medical discipline, felt itself under siege. There were a lot of things that were causing the public to lose confidence in psychiatry. One, it was seen as, there was criticism that psychiatrists function more as an agency of social control than a real medical discipline. Mm-hmm. Mm-hmm. There was some sense that their diagnoses were neither reliable nor valid, which is what you need in a medical discipline. We had something called psychiatry. There was an anti-psychiatry movement that arose within the academia. We had patient groups picking up on the ex-patient groups, people released from mental hospitals, picking up on the civil rights movement in the United States, saying, we want our civil rights. We want to be free of psychiatry, psychiatric survivor movement. Then the benzodiazepines were seen as addictive. That was a popular drug. And finally, there was the two things that really triggered the sense of being under siege. One was when, what was his first name? Rosenhan did as an experiment. He was a psychologist, and he went into emergency rooms, him and 8 of his students, and they complained of hearing a word, thud, or something like that. They were all admitted, diagnosed as schizophrenic, and the psychiatrist supposedly never recognized them as imposters. And so when they published this, which got a lot of notice in Science magazine, it was like, look, psychiatry can't tell insanity from sanity. So that was a real blow to its credibility. In fact, a week after that publication appeared, that's when the American Psychiatric Association said, we've got to change. We need to set up a task force to recategorize psychiatric disorders. And then there was a famous movie in the United States called One Flew Over the Cuckoo's Nest, which made fun of psychiatrists. So psychiatry, if you look in their archives, it says, we don't have real credibility as a medical discipline. That's number one. 2, we're in competition with therapists, psychotherapists, and counselors, and we can't prove that our form of psychotherapy is any better than these others. And they're sort of making fun of us as Freudian shrinks. So they said this: what gives us an advantage in the marketplace? What is our advantage over the counselors and the psychologists? It's that we can prescribe drugs. So they said what we need to do is dress ourselves in a white coat, which at least in the United States at the time was the dress of the doctor, the infectious disease doctor, etc., and present ourselves as doctors that treat real diseases of the brain. And you can read this, they're going to say this. So they create DSM-3. And as they create DSM-3, they said, this is our new thought, that these are distinct diseases of the brain. But here's the problem. They didn't find that to be so. But having said we're going to categorize depression as a disease of the brain, now comes the desperation to prove that everybody with those symptoms has a neurobiological problem. So what happened is American Psychiatric Association published a book which reconceptualized all mental distress as diseases. They call it a medical model, but really as separate diseases. But that arose from a guild need, a need of the psychiatry as a medical guild, and not from advances in understanding what was going on in the brain. Once they made this, they began selling this disease story to the public and to themselves in their textbooks and all. And that's when we began hearing about chemical imbalances. But the problem was they weren't finding sort of any characteristic pathology for any disorder. That's what happened. But that's why the desperation, because this is how they wanted to see themselves. They exported that idea around the world, and there becomes the desperation to prove it.
That resonates. Yeah, I just had a conversation with Mia Hughes here on the show, and she also went into a bit the psychiatric history and the things that are buried, like the lobotomies, the taking out the ovaries of healthy women. And there's I think that we should, as an environment, as a community, psychiatric community, be more aware of these things, more bring it with us instead of what is going on. I mean, it wasn't. I definitely wasn't taught about how the things that we've moved away from. That's a shame. It makes us poor.
I think if you know the past, it helps breed humility for the present. Because listen, treating people. You know that the human brain is so complex. Human beings are so complex. And we're not steady state creatures. We have ups and downs. And what the past tells us is be humble about thinking you can have cures for this group of people, because there's just so many different ways that people end up here. And the other thing that I think from the past that really helps inform us, it says, you talked about lobotomies and sterilizations, that sort of thing. If you have a conception, which is what we had in the United States beginning around 1900 to 1945, a eugenic conception that these people were less than, they had bad genes. That's why they were insane or manic. They were genetic defectives. And that's why you get the sterilization and that sort of thing. But doctors start saying maybe it'll, cure them. But what does the past tell us? The minute you start drawing a fine line saying over here are the mad or the ill, and over here are the normal people, you get problems because you'll do things to the mad you won't do to yourself. And you even start saying, oh, the mad they're not reliable witnesses of their own lives, right? They don't know they're sick. Well, the minute you start taking away from people sort of that self-agency and that ability to self-report what's happening to them, that's a recipe for bad medicine and doing harm to people and doing things that will silence people like lobotomy, but it's not curing anything. And you're not respecting the value those people have as their own, as individuals. So why do we know the past? Because we need to have that humility to inform what we're doing today.
And how would you, because you work a lot with that now, right? You're talking about rethinking mental health and different approaches. Will you tell me about that? How do you see that happening?
Well, this is really why we started Mad in America, the website you mentioned. It's a web magazine. And when we started it, we felt that rethinking psychiatry was really a societal obligation. How are we going to care for people who are struggling in some ways? And here's what we thought was necessary. We bring forth, so we have a science team that brings forth, peer-reviewed articles that are never promoted to the public precisely because they don't fit that conventional narrative. So you can go on our site and find all sorts of research about what is the effect of antidepressants over 6 weeks in real-world patients, and you'll find a bunch of studies, and they seem to about 25% have a good response after some period of time. But you can also find a number of studies that show long-term outcomes seem to be worsening. And you can see papers that explain why they think that's so. But none of that is normally given to the public. So first of all, we felt society needs to base its thinking on a knowledge, an awareness of what's in the scientific literature and not the marketing story that's told to us. That's number one. Number two, we felt that in the United States, the story is that people who aren't well, you can do things to them because they lack insight into their own illness. What we said is, no, the voice of those who have been treated, they need to be part of the discussion, and especially those who feel they've been harmed. So we have personal stories where people said, this was my experience in psychiatry. So we think that the lived experience of people is so important. Then third, there is a sense of it's sort of a diagnostic sense. How should we be conceiving of these problems? So what we'll have is research talking about what is the genetic influence, very low, but what are the environmental influences on this, very high, and things happen to people, et cetera. And then finally, so we want people to think about not just the efficacy of the drugs, but what do we know about the diagnoses? Have they been validated as real diseases, that sort of thing? And what does it really mean? And then we'd like to report on initiatives that are less drug-based. They may use drugs in some sort of selective use model and are reporting good outcomes. And it might be for kids in schools that are taking a different approach than just giving stimulants to kids. It might be something with depression where they get them in different environments, exercise, helping out in volunteering, that sort of thing. And even with psychotic disorders, programs that are meant to sort of use the drugs on a selective use basis, because we had a good research from Northern Finland that adopted that model of care in the 1990s, open dialogue. And they basically found there's one group of people that have psychosis that can get better without ever going on the drugs, another group that needs them at time, and then a third group that needs them regularly. So it's a selective use, best use model. So that's the final thing we say, like, where is there research with an evidence base that we can make known that can help govern our thinking? So that's what we try to do.
Okay.
But we, Mad in America, don't think we have the answers. We think we should be a provider of information to help inform a societal discussion, including that can inform psychiatrists, psychologists, the professionals, family members. That's our job.
So you're clear on that. There is a group of patients who do need these drugs. You're not throwing the baby out with the bathwater.
I think the drugs have to be used in a thoughtful, informed consent manner, which makes information about their short-term effects, adverse effects, and really does address long-term impact. But to your question, yes, I think they can have a place if used within what we don't know what they're really doing. They're not fixing a chemical imbalance. But do we know some people that have responded well to medications, particularly over the short term? Yes. Would you want to throw that out? No. And I do think there are some people long term that seem to do better on the medications. When you talk about drugs worsening long term outcomes, it's in the aggregate, and it's against the foil of what is the natural capacity to recover. So if you have what's the natural course of the disorder, and for example, in the 1970s, and then later on, they said, what is the natural chance of recovering from a depressive episode, including hospitalized depression? And the thought it was this: 85% will be well in 1 year. And in terms of long term, you're going to have this spectrum of outcomes of a first episode of depression. 50% will recover and never have another episode. 30% or so will they'll recover and have an episode maybe every 3 or 4 years. And then there might be 20% that become chronically ill. Okay. In other words, for whatever reason. Well, in order for antidepressants to not be seen as worsening outcomes in the aggregate, they have to beat that spectrum of outcomes. Yeah. But that doesn't mean that nobody is doing well on the medication. So what you have to really adopt is a selective use model that figures out for whom and for how long. It's got to be a thoughtful use. I do think Nasser Ghami was right on the money when he said we really should be trying to use these drugs for as short term as possible and as low doses as possible. That's what he came up with after a thorough review of the evidence. Yeah.
Yeah, we're prescribing way too much, and also to children. But yeah, there are also too many patients. I hesitate to call them even patients, because we're being referred people who I wouldn't call them sick. I wouldn't say that they have really symptoms even. It's and I think you also wrote about this, the inflation of the diagnostic system. Have we covered that yet? Because I think that's really important.
It is really important, because real depression used to be fairly rare disorder. Okay, if you go back to before 1980, they looked at the prevalence of it. It was like 1 in 400 or something. 1 in 500 would have a depressive episode each year. But now, what happened after post DSM-3 and sort of the popularization of the SSRIs and Prozac and this miracle drug, it's now seen by the public as something that, you're not feeling, your life's not going perfect. You have some sort of discomfort. This is the drug will take away your discomfort. And it's basically changed how we conceive of ourselves and how we think of life. So and you guys I'm talking about, psychiatrists are in a difficult position because this cultural concept has been pitched to societies, and they think they can come and get a pill that will make their difficulties go away. But this, of course, is part of the problem, is that, listen, in the United States, they say 25 to 30% people suffer a mental disorder each year. Think about that. And of our children, about 25 to 30% now arrive on campuses with a diagnosis. That tells you what you're doing is you're pathologizing a huge swath of your population, pushing them into this camp. And once they're pushed into the camp, that's a problematic thing to do. And also, I think it steals resources from people that really do have more serious problems.
This episode is also sponsored by Violet Nails, where I've been going to for years. It has a bunch of things from eyebrows and massages, mani-pedis, and the result is always so smooth and elegant. And the best thing, I think, is that the treatment never lasts longer than planned, which is important when you have places to go and kids and all of that. You can sit in a massage chair while you get your treatment and listen to music. It's a really good time out. So go to the link below and check it out.
Yeah, I think there are several problems. You also, because you have such a diagnostic system that just catches everything, the sheer amount of patients, and also that people know that there are drugs that they can get. So there's this, they also ask for it.
Sure.
That's a problem. We don't have a lot of time. I hesitate to believe that there's a malice behind psychiatrists' wish to prescribe, because we aren't the ones, I looked at my fellow students who went into this path. We're the ones with the most empathy. It's just, the sadists, they went in to study something else. The ones who wanted to just sit in an office and make the big bucks, they became dermatologists or ophthalmologists. So, having listened to a lot of this and I wanted to do a deep dive into this topic, and there's always the malice prescribed to us. I think we're in the middle of a perfect storm.
Well, I couldn't agree more. I don't think people go into psychiatry with malice in their hearts. It's not where they go in. And I don't think they develop it either. But the problem is you practice within a cultural context. And there's two contexts you practice with. There is the cultural context where, by whatever, there's been various means to make this happen. People want the drugs, right? They've been motivated to think that there's a drug out there that they can come get that's going to help their lives. And I don't know how it is with parents in Switzerland, but a lot of understanding now of parents, if their kids aren't excelling in school, they must have something wrong with them.
Absolutely. I have that as well. It's all over the West. Yeah.
Okay. So you can get a pill that'll help your kid in school. Anyway, but there's another context, and you approach this, for at least in the United States, you said in Switzerland it's different. You can get paid for psychotherapy. The doctors here, the psychiatrists here are getting paid to be psychopharmacologists, to do 15-minute checks. And if someone has psychotherapy, they go to someone else. So this is their product. This is what they're expected to do. It doesn't come from malice, but they're in a box within our society where it says these are the people who prescribe psychiatric drugs. So, by the way, you can't be a doctor and not sort of believe in the merits of your product, Because you're not a sadist. You have to sort of believe in them, right? And then the other thing is, you have textbooks. You're taught it's evidence-based medicine. You go to continuing medical education things. You're part of a tribe and then there's protocols. You're not supposed to, at least in the United States, you can get in trouble for not adhering to protocols. So you guys, psychiatrists, when I say you guys, psychiatrists practice within a cultural context. And I couldn't agree more. Don't assign malice to them. The problem begins with this cultural context. Now, the people I do find problematic are those in the United States, academic psychiatrists who got money from drug companies. And once they did, they were fine with spinning results, hiding adverse events. And often these academic psychiatrists, in fact, don't even see patients. They're making their living, writing textbooks, doing things for the drug companies. They betrayed not just society, they betrayed their own profession because they kept information from, and we have a big scandal here in the United States that's ongoing right now, but they kept from their own profession the information that they need to be thoughtful users of these drugs.
Yeah, we're very much a part of the problem. I saw that as well when I was working, and when I did my residency, we did these rotations, different departments, and there would always be lectures, and in every lecture, the head of the department would talk about the diseases that they treated, and they would always rave about these high numbers, and then at the same time how well the treatment works. worked and then would go to the next department and it would be the same. The numbers were really high. There's so many people just suffering from this. So many people have ADHD, so many more people than 10 years ago. So we are really important. Oh, this is the most important disease. It was on repeat. And also the treatments were so good. And I said, just looked around. These things can't really be true at the same time, can they? That the treatments are so effective, but the numbers keep rising. And they were I just noticed that it was important for them to be relevant, obviously. So they wanted the sufferer number to be high.
Yeah, I think this is every medical profession wants to believe in itself, right? And its importance and the efficacy of its treatments. And then you get the people who become the stars in the field, the ones writing the text. And then they start, they really want to promote sort of the efficacy and the fact that more patients are coming rather than seeing it as a sign of a failed form of care. They see it like, oh, really, we're needed more than ever. But it's something that comes within the field of medicine and becoming a leader. You don't really benefit if you start criticizing what you're doing too much, right?
Yeah.
That generally isn't the way to stay a star of the department or the field or in your country. So can I ask you a quick question?
Yes, please.
What do your colleagues think of you hosting a podcast called Psychobabble? They probably don't like the word psychobabble.
No, so I'm not hired in an institution at the moment, and I don't expect ever to be hired by an institution again. This is now I've gone completely private. I've lost contact. Yeah, I've lost people.
I bet you have.
That's definitely happened. I just said, I'm trying to help more people than just one at a time. And I think that this is so necessary.
Well, it contributes to helping spur a societal discussion about what have we been doing and what might we do different to have a podcast like this, because you're prompting people to think about what we know or don't know, how we might change things.
I think so. And I think courage is contagious. And I hope that they'll sort of follow. Yeah, I've noticed that when I speak up in a group of women, they'll be sort of, they won't agree right then and there, but they'll come and speak to me privately after because I speak up against ADHD medication. I'll tell them, that they're amphetamine derivatives and that I've never seen patients come off Ritalin. That's for life. And they're like, what? They are? They've never been told this. Oh, wow. But there seems to be a sort of a movement now of parents being more careful with this medication. Is that something that you've seen?
Well, the diagnosis of ADHD is getting ever more popularized. And so they moved it from kids to adults now so everybody can do it. Here's an example of where the experts in the United States betrayed the public, and betrayed basically everybody in the ADHD field. So we did a big study. By we, I mean the United States. The NIMH funded a big study called the MTA study of ADHD in the 1990s. And when they mounted this study, they said, this will be this. We've never done a study that really looks at how kids so diagnosed do over the long term. And when they mounted that study, they said, we have no evidence that it's really helping people function better, do better in school, any long-term benefit. They said, this is what we're going to do. So now it was designed in a way that's a little bit odd, but it basically compared drug treatment to behavioral treatment, okay? And at the end of 14 months, they said the group that was treated with drugs they had reduced ADHD symptoms compared to the behavioral group. And they were actually doing a little better on reading tests. So that became, they said, this is evidence why they provide a long-term benefit. And you can still read that citation at the end of 14 months justifying the use of stimulants. But that study didn't end there. It continued. And at the end of 3 years, being on stimulants was a marker of deterioration, not of benefit. But that's never told to the public. It's not told to you. It's not told to prescribers. At the end of six years, being on drug was associated with functional impairment, cognitive decline, increased delinquency, and increased ADHD symptoms, and the people were shorter. And researchers were so startled by this, they tried to say, well, maybe, even though it was initially randomized, after 1 year, it became more of a naturalistic study. People who were on drugs could go off. People who weren't on the stimulants could go on. And they said, well, maybe the reason for the worst outcomes is the people who stayed on had more severe baseline symptoms. But they found that wasn't true. If anything, the opposite was true. So at the very least, you as a prescriber should know this information, right? The world should know this information, but it never is promoted. Not the 3-year results, not the 6-year results. Every once in a while now you'll hear the, whatever it is, the 10 or 15-year results where they'll admit there was no long-term benefit. But the problem for us is a journalistic problem in a way. Why isn't this communicated to the public? Well, when I reported on this, one reason is virtually everybody in that study was taking money from the drug companies. So they didn't want to report that stimulants weren't effective, that Ritalin, for example, wasn't effective. And you're right, of course, they're amphetamines. And anyway, this is part of the problem is we're not operating in a larger society of informed consent because they hide results that are dispiriting to the profession.
You talked about how schizophrenia has occurred over the years and that now we're seeing a different type of schizophrenia than we did before. Can you say something to that?
Yeah, I mean, there is a sense that if you look at presenting symptoms of people diagnosed with schizophrenia in 1910 or 1920, 1930, it's very different from presenting symptoms today. So, and that you do hear people saying that this concept needs to be retired because it's being applied to a very disparate group of people. And people can actually have a lot of different conditions. And actually, there is a disconnect between people so diagnosed in 1920 and people so diagnosed today. So that's the first thing is I think the term is a confusing term. And you have people like Robin Murray, who's a very well-known schizophrenia doctor and psychiatrist in the UK saying maybe it's time to retire this, that sort of thing, because it is a catch-all group. And that doesn't allow you to start distinguishing between the different types of things that may be going on, bringing people to this diagnosis. But then the historical part, so that's one thing. I think you just need to rethink about what's happening with people who present with psychotic symptoms. And, maybe they persist and get diagnosed with schizophrenia. I don't think no one really thinks it's a discrete disorder. But here's the other thing. There's two things that I was mentioning. One, you look at what were the announced recovery rates for this diagnosis in like the first third of the 20th century, from 1900 to 1933. First of all, there were people who actually that would recover, even though we've sort of forgotten that. And then you see it gets a little better in the 1950s, and then it sort of levels off. And then from 1970s on, it starts going down. And then you know what it is since the arrival of the atypicals? It's now the lowest recovery rate in the history of this disorder. It's now about 6% long-term recovery rates. Really, you saw in even the first third about 35%, something like that. So that's the first part of it. There isn't this story of progress. Now, the next thing is this. When Thorazine, I think you called it Largactil, and I'm talking about the chemical chlorpromazine. It was introduced in 1955. The conventional history is this is what made it possible to empty the institutions, the asylums, and made it possible for people to live in the community. And you have, for example, a very famous book by Edward Shorter. He's a historian of psychiatry. And he said, the introduction of chlorpromazine was as profound an advance in medicine as the introduction of antibiotics in infectious disease, which is a wow statement, right? But now go back to this. Go back from 1945 to 1955 and look at discharge rates for first episode schizophrenia patients or first episode psychotic patients. And I did this for Norway. I did it for the US, and I did it for, I forget, England. And what you see, we believe that nobody got better at that time, right? Well, in fact, discharge rates would be about 2/3 at the end of one year. And if you go 5 years later, following the first cohort of schizophrenia patients, around 2/3 or even higher would be living in the community, okay, and working, actually. This is in prior to 1955, the introduction of the drugs. So you'd see like one group that basically would have a time of schizophrenia and get better. You'd have a second group that recovered enough they could still function. They might be odd, and only about a third that became chronically ill. That belies the story that no one got better before. Now, what happened in the 1950s and 1960s? It's really interesting. You see clinicians saying, oh, my patients are getting better faster than they used to, but they're relapsing more frequently than they used to. They're coming back more frequently. And they even came up with a term, at least in the United States, calling it the revolving door syndrome. And then you see like a comparison of outcomes from people treated in a hospital, say, from 47 to 52 without the drugs compared to similar patients in 1967 at the same hospital. And what you see 5 years out is higher relapse rates and more functional impairment for those on the drugs. So right away, if you actually look in the research literature, rather than see this great advance in outcomes, people getting out, higher discharge rates, you don't see higher discharge rates. And what you see, and there's even a Norwegian study that sort of hints at this, by the way. You see some worry that actually what's happening now is we're increasing the chronicity. And they even came up with an understanding of what's happening, and it's sort of the lithium story. People go on the antipsychotics. They don't like how it makes them feel. They stop taking the drug. And what they found in the 1970s, once that happens, you're at more risk of relapse than in a natural course of the disease. And you're at more risk of severe symptoms. And that comes out in the NIMH in the 1970s. And then there's researchers that even come up for a biological explanation for why antidepressants are making people more biologically vulnerable to psychosis, which makes coming off the drug so problematic. So that's a counter story that we don't hear, but it actually was present. And within the NIMH, you know what they said? NIMH is our, big thing by the end of the 70s. We should be trying to give everybody a chance to come off these drugs, because there was a famous paper called "Is the Cure Worse Than the Disease?" But we never hear of this anymore. And again, you saw with open dialogue in northern Finland a way to use these drugs. They're not anti-drug with open dialogue that they developed in the 1990s. It was like they have a place. We first have a time where we see if we can get people better without the drugs. By the way, there was an experiment in the 70s run by Lauren Mosher, head of NIMH, that did exactly this. And they found that a significant percentage could get better without going on the drugs. Then there was another group that needed the drugs for a time. And then there was a third group that needed them long term. Now, you see that separation of the medication need over and over again in the research literature. And exactly the percentages are, but what you really see over and over again is that maybe only about a third of people who present with a psychotic episode, maybe even less, really need to be on the drug forever. It's a very different sort of presentation of the spectrum of outcomes and the spectrum of need.
But that also reaffirms a little bit that the real problem is in the diagnostic system. It's in this, that we're pulling things together that have nothing to do with each other.
I couldn't agree more.
Yeah.
And actually, this is what they said in with the open dialogue people. We need to see, we don't really know what is happening, but people sort themselves out. We have to have a system of care that can help people sort us out. I couldn't agree more. This is the problem. You're lumping everybody together, and they're not lumped together in nature.
Thank you so much. This was really great. Exactly what Psychobabble is about. Exposing bad therapy and false narratives.
Exposing false narratives is so important, because bad therapy arises from false narratives in a way. So the downstream. Anyway, great. And love the title of your podcast. Psychobabble couldn't be more appropriate.
Exactly. Thank you so much.
Thanks for having me, Hannah. It's really been a pleasure.
Thank you.
Bye.
And thank you guys so much for listening to Psychobabble. Thank you for the support, and join us on Substack. Join us on YouTube. There you can always get in touch with me if there are topics you want covered, or just comments, feedback. If you want to help me out, like and subscribe. And I'll see you next time for another great episode. Have a nice day.